Hello, and welcome to our series of webinars on the regional care organizations and the health homes. Today, we will be talking about implementing health homes, lessons learned as we go forward. On our agenda, we will talk about the health homes and give you an overview of what they entail, as well as their services and benefits. And then we have some guest speakers today to talk to us about success stories from the patient care networks, which were the health home programs before April 1st. After that, we will take questions and talk about next steps. So, what is a health home? A health home is a Medicaid state plan option that integrates and coordinates primary care, behavioral health, and long-term services across the lifespan beneficiaries with chronic conditions. Our health home program in Alabama went statewide as of April 1st. Before that, we were called the Patient Care Networks of Alabama. The Patient Care Networks were only in 4 geographical areas across the state. They were in the Huntsville area, Tuscaloosa, Opelika, and Mobile. In 2012, Medicaid modified its Patient Care Network program to exclusively focus on health home eligible recipients in Patient First, and these were recipients who had chronic conditions or a behavioral health condition. At that time, our primary medical providers began receiving an expanded case management fee for those patients who qualified for our health home program and received $8.50 per member per month. These were for our patient first providers, except for those who work in our federal qualified health centers and rural health centers. So who qualifies for the health home and can receive care coordination? The health homes provide quality-driven, cost-effective, culturally appropriate, and person and family-centered health home services for patient-first recipients with the following diagnoses: asthma, diabetes, cancer, COPD, HIV, mental health conditions, cardiovascular disease, substance use disorders, transplants, sickle cell, heart disease, obesity with a BMI over 25, and when we expanded statewide April 1st, we added the diagnosis of hepatitis C virus. Now we'll be discussing the health home program services and their benefits. The health home program is set up to add an additional layer of support to patient first PNPs for those patients with the chronic conditions that we mentioned earlier. And the health homes provide this in several different ways, and we're going to talk about each one of these. First is the care coordination. Care coordinators are made up of nurses and licensed social workers who meet the patient wherever they may be. It may be in their homes, it may be in the physician's office, or wherever they would like for us to meet them. The nurses and social workers meet with the patients or the recipients to complete a comprehensive assessment to determine what needs there are, what are the obstacles to them getting the best care that they need, and to be able to manage that chronic condition or that behavioral health condition. Once they identify these needs, they develop a care plan with the patient and in coordination with the PNP. Referrals are provided for needed resources, and those may be things such as transportation, financial assistance, food and support services. And they also give support to the recipient and their family to provide education regarding the chronic illness, as well as support in making sure that they keep those appointments with the physician and take care of their own needs so that they can manage their chronic condition. A second program that we have is the Transitional Care Program. The Transitional Care Program is there to help patients transition from one setting to another. Usually this is either from long-term care or hospital setting to the home, or perhaps an inpatient psychiatric setting. Transitional care is primarily run by nurses, but they also use licensed social workers in this program as needed. As I mentioned, they assist patients in transitioning from the hospital to the home, to the community setting, and they do this in a number of ways. They may need some assistance in making their appointments or getting equipment for the home. It may be that the transitional care nurse needs to partner with those medical facilities to develop discharge plans to make sure that that patient is getting what they need. Traditionally, in discharge planning, you have staff in the hospital that made the plan, then the patient went home, and that was the end of it. With our Health Home program, the transitional care nurses and the social workers will meet with that patient in the hospital and then follow them into the home setting. So they'll actually be making home visits to see that the patient is getting what they need. In addition to what we've mentioned, there's also medication reconciliation. The social worker or the nurse goes into the home, makes sure that the patient has the medications that they need, looks over the prescriptions, and then gives that information to the pharmacist to make sure that there is nothing that is an adverse reaction from what other medications they're taking. Another real benefit of this is that many of our patients are followed by hospitalists in the hospital who may not know what all Medicaid covers and could possibly subscribe the medication that they can't get from Medicaid. The pharmacist can then work with the PNP to find a medication that this patient can afford. In addition to the Medicaid reconciliation, our pharmacists with the health homes can provide education to recipients regarding their medication management or work with the care coordinator in getting what they need. So what are some health home benefits to our physicians? One of the really great benefits for physicians who decide to sign up with the health homes is they can actually have a care coordinator that works in their facility. If they have a large panel, they may have a care coordinator who is there full-time, or they may be there once or twice a week, so that when a patient comes in who needs services, they're right there in the office and can see them there. Another benefit is integration of medical and behavioral health. We have found in some of our health homes that patients who have a behavioral health condition are making those appointments to the community mental health centers or to their psychiatrist or their therapist, but they're not following up on the medical conditions that they have. So our health homes have worked diligently to make appointments for our patients so that they are getting that care. With that integration of medical and behavioral health, they're also making sure that that PNP is getting the information they need from the community mental health center, as well as the community mental health center getting that information from the PNP. A third benefit for the PNPs are that they can network with other physicians in their region. They meet quarterly to go over initiatives to see what's working in practices. They may look at data and see that one physician is really doing a great job of getting those EPSDTs done on time, much better than other physicians, and they can share with them why they are so successful. So it's a great opportunity to network and help improve your practice. I recently talked to a medical director of one of our health homes who has been doing this now for 2 or 3 years. And I asked him, since you've been involved in the health homes, has it made you change the way you do your practice? And he said absolutely. He's made a lot of changes in his practice just because of the information that he has received from the health homes. Another benefit is additional time for staff. With the care coordinators being there, or with the care coordinators being just a call away from your practice, that's going to give the physician's staff time to do other things, so they're not having to work out transportation or making referrals to community resources. They can leave that to the health homes to do, and they can work on doing other things that are so important for the PNP in their office. So what are the benefits to the patient? Well, one is what we talked about before, and that's that transitional care and helping that patient go from the hospital setting back into the community. The assessment that the nurse and social worker does can help them see what needs they have and what barriers there are to care so that they can help with that. As we mentioned before, there's the medication assistance. They may not understand that taking that medicine is better at night instead of the morning. They have a nurse there to help them with that, as well as a pharmacist to help determine how best to take their medications. The referrals to the needed community resources is also another benefit to that patient, as well as, again, linking medical or behavioral health services. And then the component of education on chronic diseases. This is a huge help to the family and the patients. Oftentimes when you're in the hospital, you get that education, but when you get home, you just can't remember what they said. So it's helpful to have a care coordinator going out to the home on a regular basis, or the transitional care nurse, to help emphasize what that education was that they received in the hospital, to make sure that they're getting what they need. Now I'm going to turn it over to our guest speakers today. We have two people from the Care Network of Alabama, which used to be the Patient Care Network of Alabama, and that is Julie Wells and Tammy Rowell, to talk about success stories that they have had with their health home. Julie?
Thank you. Since we started Medicaid care coordination in August of 2011, we've had a number of different types of success. We've had reduction in cost and reduction of utilization of services, improved health, but today I decided to focus on a success story that really talks about the integration of improving health or improving mental health as we accept physical health diagnosis. Tammy is with me today, and she actually has had the pleasure of being the care coordinator for the patient that we're going to talk about a little bit, and she'll be available to answer questions if you have any later. So in tying to Carolyn's description of the health home model, this particular patient was a 33-year-old female. She did have a history of congestive heart failure and was being referred for evaluation for heart transplant. In the data that we received and analyzed through our program, we did see that she had 5 emergency department visits in a 12-month period of time, and one of those did result in an admission. We did identify her through the transitional care piece of the health home model because she was an inpatient, and as she was seen through that transitional care nurse, the transitional care nurse made the decision to go ahead and incorporate care coordination at that time. So she did contact our social worker so that they could begin all of her care and coordination together. In health home terms, she was risk stratified as a high, which indicated that she was high risk for frequent access of care, maybe excessive access of care, and high cost. So what did we do for her? We referred her to a number of services. This is traditional community-based social work care coordination. So we have a telehealth linkage that was done through the Alabama Department of Public Health. She was referred for transportation assistance in 2 different ways. One was a local county resource, and the other was the Education of Medicaid's NET program that was conducted for her. She did have difficulty because the severity of her illness of utilizing all of her visits and exceeding her 14 number of visits that she's allowed through the Medicaid Patient First program. So she had some education about how best to utilize services through her physician, through calling people rather than presenting, as well as working with those physician practices on the referral processes that they were utilizing. We'll talk a little bit more about her nutrition education in a minute, and mental health. Just to give you a little bit more information on her, her congestive heart failure there was an exacerbation in a pregnancy. Remember, she's 33 years old, so she's not terribly, I hope to think she's not terribly old. And she had this baby and became very sick, went into congestive heart failure, and clearly is not in good health because she is being considered for a heart transplant. Her experience in being evaluated for the heart transplant was that she wasn't appropriate initially based on weight, and so we did involve the nutrition education, and we'll talk a little bit more about that. So what happened with her? She did become active in the telehealth program. That referral was for hypertension and congestive heart failure, and she currently has what would be considered well-managed blood pressure. She utilizes her community resource for transportation, and kind of one of the gold standard of success in transportation education in our program is, can the adult Medicaid recipient learn the structure, learn the process for the NET program, and self-report and receive their funding? And that is happening, and that's a huge success. I actually have an error on this slide. It says through her nutrition education and physician follow-up, this slide says her weight loss was at 80 pounds. As of yesterday, her weight loss was at 115 pounds, which was significant. Unfortunately, that was not enough to have her listed for heart transplant, and we'll talk about that as we go into mental health. In the mental health referral system, Tammy, who is her care coordinator, and our transitional nurse worked extensively with her to talk about what was the concern. Obviously, she has a young family. She does have some adult family support, but it is limited. And there was great discussion on what type of mental health would she benefit from. She became able to articulate she was interested in doing community-based mental health center counseling, so she was referred for that. Another small success that we found in this story was at one point she's hospitalized, she misses an appointment, she calls and reschedules that on her own. And when I talk about Medicaid care coordination with this population, I really do try to stress the need to redefine what success is. We're not always going to be able to keep people out of a hospital, but if we can, her ability to utilize her appointment structure and call people on her own, I think that was a wonderful thing. I love the ED utilization. She did have 5 prior to enrollment. Since she's been enrolled in care coordination, she has not accessed the emergency department at all. Again, we're talking about someone who is not in good health, but she is following through in her appointments. She's contacting her providers. Her most recent appointment with her specialist care indicated it actually provided her with some conflicting information that was very confusing for her, which would be confusing for any of us, especially if we're looking at options that could also consider end-of-life care. And she is able to articulate that, talking about how she's going to work with mental health and just her overall acceptance of where she is as a patient, where she is as a family member, and who will be available to assist her as she moves forward in this journey with her diagnosis. So that, I thought, was a nice example of the type of involved social work care coordination that we are currently providing.
Thank you for that success story. Clearly, you've certainly made a difference in the life of this patient, and hopefully she will continue to improve and to continue losing weight. We are now going to answer some questions that we have received, some questions and answers before we take questions. The first question is, will patients who receive health home services be homebound and not come to doctor visits? This is one we get a lot. Health home is not home health. You can blame the federal government for that title of health home. It can be very complicated. Health home services provide intense care coordination for recipients with chronic conditions or serious mental health condition. These services include a social worker or nurse to assist patient through community resources, education, and transitional care services. The second question, can a PNP have patients in both a health home and in Patient First? Yes. In order to participate in the health home program, you must be a Patient First patient, or you can opt into the health home program as a dual eligible recipient. What is the incentive for the patient to join an RCO or health home if they can just stay in Patient First? Well, this incentive is what we've been talking about throughout this program today. It is for patients with chronic conditions to join a health home to get comprehensive care management, care coordination services, and transitional care services they would otherwise not receive in the Patient First program. In order to get those services, you must be in a health home. But you can be in Patient First without that. So what if some patients choose not to participate in the health home, but are still in the Patient First program in the next 1 to 2 years? Recipients who qualify for health home services can decide if they want the extra services or not. It is their choice. Also, if you're in a region that has more than one health home, you have a choice of which health home you would like to participate in. If a Patient First recipient qualifies for the health home but decides to stay with a PNP who is not signed up for the health home program, that patient will still get Medicaid services but will not get any of the extra services available through the health home program. If they decide they want health home services and their physician has not contracted to participate in the health home, they would need to change their physician to someone who has, but that is something that is available to the patient. How are providers who are not Patient First providers, for instance, skilled nursing facilities, assisted living facilities, and hospitals, affected by the RCOs in the health homes? The primary goal of health homes includes the integration of care between medical, behavioral health, and long-term care services. In order to achieve this goal, health home staff must develop relationships with medical facilities and community agencies in addition to the Patient First providers. This is just an explanation of what we've been talking about, of partnering with our hospitals for discharge planning, our psychiatric facilities, and making those community referrals. What happens to the health home program when the RCOs go live? The RCOs will continue to provide health home services to qualified recipients after they become full risk on October 1 of 2016. Your slide says 15. Oh, it says 16. Someone corrected it. That's good. October 1 of 2016. That's one reason, this is the primary reason why we have health homes that are now part of the regional care organizations. So what are the next steps? Here is contact information for each of the health homes that began on April the 1st. We have placed the executive directors' names and their phone numbers here. The providers may contact the probationary RCOs to get additional information or to let them know that they would like to contract with them to provide services in the health home program. We are also going to be putting this on our Medicaid website under programs and health homes. The agency wants to support you in any way we can. On this slide you can see our first page on our website. Many people call in and say, where can I get more information on regional care organizations and health homes? If you go to the bottom left-hand corner of that screen that looks like a little house with people in it, it says regional care organizations. Click on that and that will get you to where you need to be. In addition, in the top toolbar, you can see where it says programs, and there is now a new page that says health homes for those programs. It is the goal of Alabama Medicaid to have a seamless transition to the statewide expansion of the health home program. And so that is why we were here today explaining this. We're going to continue this discussion on April the 22nd with our upcoming noon webinar, which will be the health home from the PNP perspective. Our contact information is here. If you have any questions, please submit them to the RCO portal at medicaid.alabama.gov. For any PNP assistance, you may call our Assistance Center at this 1-800 number. Thank you for joining us today.